Mental health. Come on down. I think we have Joanne Fuller, Health Department Director, kicking things off.
And while they're coming down, Madam Chair, maybe I can introduce this a little bit because we're going to have a really diverse cast this morning representing a very wide array of stakeholders in what is a really important topic. The mental health crisis system that plays an essential role for so many people in the community. I thought it was timely to learn more about the services that make up this system to stabilize and treat individuals in crisis. It's been over 50 years since President Kennedy signed the Community Mental Health Act into law. The president had some personal experience with mental health issues and in his family. And I think that what we find is that many of the leaders in this topic also have had experiences and frustrations with how the community has failed to address mental health crisis. But it is heartening to see the individuals that we have today to present who work tirelessly to fill out a continuum of care for Multnomah County. So, Joanne.
Thank you. Thank you, Madam Chair, members of the Commission. Joanne Fuller, your Health Department Director. And I have with me today Neil Rotman, who is a Senior Manager in the Mental Health and Addiction Services Division. And we're expecting David Hidalgo. We're running a little bit ahead of time, so I'm expecting him to join us. We also have with us representatives of a variety of organizations that are our close colleagues and collaborators in the creation of the crisis system, and you're going to be hearing from them as we go through this presentation. What we wanted to do today was to give you a little bit of an orientation about where we're at in terms of the development of a crisis safety net for mental health services in Multnomah County, and talk with you about the exciting developments that are happening in that system, and then give you a sense of a timeline for the completion of those opportunities and our continued assessment of what we need and where we need to invest our resources in this important system. And go to the next slide. So just to kind of give you a little bit of an orientation, here's an overall of the goals of the crisis system. So just so that you remember, we have responsibility for creating a crisis safety net for people who are both insured and uninsured in our community as a part of our responsibilities as the Public Mental Health Authority, which is granted us by law by the state of Oregon. And they don't necessarily make a consistent investment in this system. It's an expectation that the county provide this system. We in Multnomah County provide the most robust crisis safety net by far, by any measure across the state, per capita, raw resources, volume of services. That's not unexpected. It's also a challenge to us because we also have more hospital beds and more hospital ERs in this community, and that serves as a place that people seek access to this system, sometimes appropriately, sometimes not appropriately. And so we continue to be challenged with that easy access in comparison to alternatives that we are building. And working with other partners to build. So just to remind you of the goals, the first goal is really 24-hour access and availability for everyone. As I was saying, this crisis systems are intended to be the front door, and crisis systems that are working effectively help people to get quick and rapid access to the level of care that they need. The crisis systems that are working also divert people from higher levels of care and try to serve them in lower levels of care. That serves to create less disruption in people's lives. It also hopefully cuts off institutionalization and the trauma that can be associated with that. And it also helps us, hopefully, to avoid people winding up in inappropriate institutional settings like the jail. The system also serves, the way that we've structured the system, as a navigational system, so hopefully helping people to stay connected, letting the providers of care for individuals who are experiencing crisis know that people who are assigned to them for care are experiencing crisis, and giving those organizations an opportunity to reach out and stabilize people who are there really under their care. So, for example, if someone is seeing a case manager at Cascadia, letting that person know that an individual is experiencing a crisis that they might not know about, so that they can get easy access to stabilization. And then, it helps also allow us to look at trends in the community, look at where crisis is happening. It also gives us an opportunity to figure out what parts of the system are underfunded or under-accessed or under-resourced, so that we can figure out how we can invest the precious resources that we have. I just want to place a caveat on all of this, which is that in Multnomah County, through the course of many years of budget reductions from state funding, reductions from county general fund, met challenges to serve the Medicaid population, we have continued to experience, and I expect will experience, challenges in figuring out how to fully fund this system. And so it's a system where we're always trying to figure out how can we make sure that we have enough resource available to fund it, and to balance, if we spend every dollar on a crisis system, we don't have resources for other treatment, which is the place that we really want people to be getting their care, which is ongoing care from specialty providers or supporting their generalist medical providers to be able to provide care.
Madam Chair, I have a question. Joanne, so this is a system that we're creating. We don't have this 24/7 system to date.
We do have this 24/7 system today.
So the front door, where are those 24/7 front doors?
David, do you want to talk about that?
Sure, I'd be happy to. Good morning, Commissioner Smith.
Morning.
So the front doors of the crisis system, they're really two 24-hour front doors. That is the mental health crisis line, staffed and operated through the county, has been since about 2000. And then the mobile mental health outreach team. That is a contract that the county has with Cascadia Behavioral Health Care. Many people know that program by Cascadia's name of Project Respond, and that program is available for access through contacting the crisis line for the general public, and the other entity that has direct access to that 24-hour mobile mental health team is the police. We also have the urgent walk-in clinic that is available approximately 15 hours a day. That is also a front door to the system as well, but the other two are 24/7 at this point.
So with the police, what happens with the police? I mean, we can call the police and they will pick someone up, and what will they do with them?
So in terms of the police, the great thing is that the police really have honed a very nice connection, as has the crisis system with public safety. So the police actually have a protocol directly to know if there's a mental health outreach dispatch. They often contact Project Respond to join them on that call, or once they get on site, if they realize that there really is a need for more mental health support, they will contact Project Respond. Our last statistic, and Neil potentially can speak to that, or Cascadia can as well, approximately 50%, a little bit higher, of the mobile outreach calls are direct contact with police request. Okay. So I'd be happy to talk about the next slide. Really is about the interface of the crisis system and how it connects with the larger community systems of care or other systems. So the crisis system ultimately is as effective as its relationships with the rest of the community and its knowledge about the community systems. So as you can see, the mental health crisis system really sits as the hub, really kind of a central point that interfaces with many other systems across this community. So really, wherever people come in contact with the rest of the public is where those crisis systems have contact. So you can see at the very top, the community-based behavioral health services. Many people may think, well, the crisis system, of course, interfaces with the mental health and addiction system. Well, yes, absolutely so. And the crisis staff, the crisis teams in the system must have intimate knowledge of all the available services and all the available pathways to help access care, longer-term care. The goal primarily of crisis services is really that they are short-term in duration, they're solution-focused, and then, of course, they're also person-centered to help people get to the next step. So the goal of the crisis system is not to hold individuals in that central point, but if you will, to really act as a bit of traffic control for the larger system to ensure people get to the right spot, people can access information about where to go in the system, and if somebody really does have a mental health crisis, that crisis can be quickly stabilized, supporting the resilience and strength of the individual, supporting their recovery, and helping plan for the next step. So you can see also other services that we've talked about, that familiar word, the social determinants of health. Crisis systems interface with housing and residential resources. They help people who may be in a crisis in their home and help stabilize that crisis, helping someone to retain their housing. They interface with addiction services. They interface with our county commitment services, people who come in crisis and once again may not need a hospitalization but may need some of their help and support to move to the next step in their recovery. Jail diversion services is another area crisis services connect with. Public safety, as Commissioner Smith mentioned as well, direct with emergency services. So that's fire, that's Portland Police, that's 911. While crisis services are not a frontline emergency services, they are paired up with those emergency services because they are the behavioral health experts. They can help augment response and go ahead and improve the response for people who have a mental health crisis. Prevention and education. We're also in close contact with schools as well as other prevention programs to ensure that if there's a situation that happens in a school that leads to an individual crisis perhaps or a global crisis in the school, that crisis services can help support the school's response. Generally, crisis services, again, are not the long-term response, but they help with that very upfront, immediate stabilization in the system. So that's really the landscape of how they interface. If you have any questions, I'd be happy to answer. Otherwise, we'll pass it on to Neil.
I have just a question that kind of comes from the whole discussion of how can we invest the precious resources, and obviously, as always, limited resources that we have in this system. I'm trying to get a grasp on the proportion of contact from Multnomah County residents through the crisis service system. Do we have a concept of how proportionately the health department is contacted in relationship to mental health crisis service?
Thank you, Commissioner Shipwreck. That is a perfect lead into our next slide where Neil will actually go through the programs and the number of contacts. Could not have been scripted better. Thank you.
You were jumping ahead, weren't you?
Yeah.
Neil.
We're also anxious to get into this topic, Matt. Good morning, Chair Kafori, Commissioners. Thank you so much for the opportunity to be here this morning. The Multnomah Behavioral Health Crisis System is a continuum of interconnected behavioral health services that can be represented by the intensity of psychiatric and support services from the top end of the spectrum of hospital emergency departments, inpatient units, to the lower end of the spectrum, community outpatient clinics, and private practitioners. The crisis system can be accessed at many points along the continuum with a focus on ensuring the safety of the individual experiencing a crisis, ensuring the safety of the community, and engaging the individual experiencing a crisis to identify the least intensive intervention that supports resolution of the immediate crisis, provides connections to ongoing services and supports, and minimizes traumatic experiences. I would like to provide a brief description of each of the 7 main services of the crisis system you see in front of you. And we'll start at the top with the Mental Health Call Center, which really is the center or the hub of the crisis services system from which all crisis services can be accessed. The call center is a crisis line with brief crisis counseling and safety assessments, which can be done over the phone. It is a resource for behavioral health information and referrals to alternative services, specialty mental health services. It's a dispatcher for the mobile crisis outreach team and a direct link to 911 and first responder dispatch. It's a repository for crisis alerts and real-time community mental health information. And by that I mean if we have a provider who has a leak in their building and has to close their doors early, they call the call center and report that so their clients have somewhere to call and check in if they go to the clinic and find that it's closed for whatever reason. Our last snow episode or ice episode, that came in quite handy as a number of programs contacted the call center to give us updates on a regular basis of their staffing. It is staffed 24 hours a day, 7 days a week by mental health professionals, and we have several phone lines. They're dedicated to crisis calls, 911 warm transfers that do not meet the criteria for first responders dispatching. Law enforcement has their own line. Membership services for Health Share of Oregon, Multnomah Mental Health, and Family Care Behavioral Health Services after hours. We have a community line for behavioral health questions, concerns, and community resources and support services. In addition, the call center provides support to individuals who need brief, daily supportive or therapeutic contacts to live independently in the community. To move on through our spectrum, the Urgent Walk-In Clinic, another very vital program, is open 7 days a week from 7 a.m. to 10:30 p.m. They see individuals and families who are in crisis and need an appointment with a psychiatric and mental health professional. Anyone can receive services here, with or without insurance coverage. The Urgent Walk-In Clinic refers individuals to community mental health and addiction programs and acts as a bridge to services, which can continue to support individuals until alternative treatment services are established. A recent state grant is funding a stabilization resource room at the Urgent Walk-In Clinic, staffed with peer specialists who can assist individuals to independently navigate available support services and benefits. Next up, as we move around our circle clockwise, is the mobile crisis. As everybody affectionately knows them as Project Respond in our community. Project Respond is a mobile outreach team of mental health professionals who work in community performing on-site evaluations of people in crisis to determine the appropriate level of treatment to stabilize their symptoms. The call center and 911 are dispatches for the team, which is available 24/7, 365 days a year. The program can perform follow-up check-ins and short-term ongoing outreach to individuals identified as in a crisis episode, but are not initially receptive to engage in treatment or do not meet emergency hold criteria and thus hospitalization. Recent state grant funding added a peer specialist to this team with a focus on the follow-up contacts and supportive services. As we move down, we get to the Crisis Assessment and Treatment Center, known in the community as the CAT-C. CAT-C is a less intensive than hospital inpatient services and is often referred to as a subacute program. The center is appropriate when an individual needs crisis stabilization in a secure setting, but does not require the level of medical interventions available in a hospital inpatient unit. The program is utilized to divert from hospital or to step down from a hospital when that level of treatment is no longer needed. Medical and mental health professionals, as well as peer specialists, are on staff at the site. Discharge planning includes referral and access to outpatient psychiatric and medical treatment, temporary and permanent housing referrals, and assistance with benefits eligibility. As we move around, we come to the Crisis Respite Program. I did not mention Justice Mental Health Triage, which is part of CATSI. The Justice Triage Program is an assessment and referral program for individuals with mental health symptoms being released from jail. They would benefit from a mental health and physical assessment, and they would need additional coordination to ongoing treatment services. The The level of care needs are evaluated and may lead to a direct admission to the CATSI subacute program, or they could be referred to alternative levels of care and treatment, like respite, addiction services, or community mental health services. Participants include individuals identified with behavioral health concerns being released from jail, the Department of Community Justice Mentally Ill Offender Unit program, our own jail diversion program, or referrals from the Portland Police Bureau, the Behavioral Health Unit. All can send folks to Justice Triage for that initial assessment and referral for ongoing services. Next up is Crisis Respite, which provides an in-home-like setting respite environment, is utilized when one's behavioral health symptoms require a brief stay in a facility staffed 24/7 by mental health professionals in order to stabilize. The residential facility provides the structure and support that many need to avoid hospitalization and return safely to the independent living situation. Individuals receive medication administration, supportive counseling, and assistance with daily living skills. As we move up our circle of programs, we come to our emergency department liaisons. They are dedicated to hospital emergency department staff and social workers. They help safely divert individuals from unnecessary hospital stay and connect them to alternative treatment services. The program is administered through the Mobile Crisis Outreach Team, Project Respond, which increases their ability to make after-hours referrals and maintain engagement to crisis services until the crisis episode has resolved. And last in our circle here is the Crisis Prevention Outreach Program, run by the Morrison Center. It provides crisis services to children and families referred by the call center, Project Respond, the Wraparound Children's Team, or by Morrison staff. Outreach counselors work with children and families in their homes or while in temporary foster placement during an identified crisis situation. The goal is to address the crisis situation to resolution, develop a supportive bridge to ongoing engagement and needed treatment services for children and their families.
Madam Chair?
Any questions?
So just a sort of a bubble that is in the spaces between maybe the blue boxes on your graph, and that would be a question: are there gaps in this system? And Neil, from your perspective, what are those gaps? And again, from the commentary, Joanne, that you kind of led off with, are those gaps something that can be filled in by investing our precious resources, or are those gaps that we need to fill in with creativity or with some other kind of community work that we should be engaged? I just heard a voice say analysis. Did I?
Policies, I think you heard.
Policies, okay. My hearing isn't that great, but I pick up on this. Neil.
Sure. So I think, in our current system, this is a very strong continuum of service. So all the way, again, from the top end of emergency departments, inpatient units, down to our subacute program, down to respite, we sort of have a full continuum of services. There are some minor gaps, and when you say in between the blue boxes, I like to think that we have ongoing services. So if Project Respond is working with someone, that person is not willing and not ready to engage in regular treatment, they will continue their outreach during that episode. They won't stop. Just because that team member gets off duty doesn't mean they stop checking in with that person. They don't stop their outreach. They continue to work. We have a very strong network now working through the behavioral health unit as well. So they might take that case and staff it with other crisis services, saying, who has this connection? Who else are they touching at that point? Where are the touch points to be able to get this person engaged in more ongoing services?
I'd like to add a couple of things. I think that for the size of our community and the volume that we have, we probably don't have enough of the resources that are stepped down from the hospital. and the number of crisis respite beds that we have in this community, for example, is probably less than we would want to have. There have been challenges with keeping our crisis respite beds programs open, and challenges with they're challenging programs to cite, to build, to fund. So, I mean, I think that's an ongoing challenge. A couple other things that I think I would add, which is that we live in an environment where it's extremely easy. Well, two things. First of all, I'm not confident that our treatment system and the social service systems attached to it are doing enough upstream to keep people from becoming in crisis. So that creates more pressure on the crisis system. And I think that we and our partners in that treatment system need to do a better job of figuring out how to help people, how to identify people earlier who are at risk of going into crisis and figure out the right assistance for them, aggressive enough outreach. So I think there's that, which isn't a problem of the crisis system, but is a problem upstream of the crisis system. I think the other thing is the ongoing challenge of helping first responders, like the police, to have easy routes to get people diverted from winding up in the hospital. So if the easiest thing is to take someone to jail or the hospital, my experience with systems is the easy routes are the routes that get taken, no matter whether that's really where people want to take people. And if there are more barriers for the things that where people might be better off, or we might be able to serve them with lower levels of care, respond. But if those are more challenging for first responders to connect with, that won't happen. And I think we still have not cracked that nut completely yet. We've done a lot of great work with the police and especially with the behavioral health unit, but there's still, I think, work to be done. That's my 2 cents.
Chair. Director Full, I really appreciate the points you're making, and I think this is a really important slide, and particularly your point about the pressures in step-down care and the facilities that we have for folks. Obviously, an important addition to this slide, when it's open, will be the Unity Center. Will be a critical piece for our system and really an important gateway for how we serve this community. But I think we'll also then highlight some of those pressures in how we provide step-down care and housing and ongoing services to folks once they are out of an acute setting. So I guess the request would be, I hope that you will keep us well up to date on where we need to make targeted investments in addition to the acute side of the equation to make sure that we are supporting a system and a continuum that works all the way down with this really important piece that's being added to it.
Absolutely. You're going to be hearing more about the Unity Center in a minute. And I'll just say that at the end of the presentation, part of what I want to share is sort of my perspective, which is that the Unity Center is like, it's like when you drop a stone in a pool and the ripples happen. So once it opens and the services are stabilized, which usually takes at least 6 months for a new program, then I think we will understand what those ripples are in the crisis system pool and how we can adjust the way that we are funding resources to accommodate the changes that have happened.
I guess follow up. I would imagine that the other variable that's at play here is the changes that have happened since the inception of the Affordable Care Act, and yes, that has obviously been a game changer in the system. Can you give us, and if you don't have the numbers right on you now, it'd be great to get it as a follow-up, a snapshot of how things have changed from service levels prior to implementation of the Affordable Care Act and then service levels sort of most recently afterwards, so we can have a sense of both the opportunity and sort of the magnitude of what we're dealing with there?
We'd be happy to provide that. We don't have all those numbers with us today, but we'd be happy to provide that information to the whole board.
Thank you.
Thank you.
Madam Chair, I have a question. Neil, I'm looking at this crisis service ecosystem that you have here. One of the things that's difficult for me is I'm not quite sure who is doing the mental health call center. Is that Multnomah County or a community-based organization? So it would be helpful to me on all of these, who's actually doing the work? Who are the end providers? What are their telephone numbers? And the dollar amount for each of these services would be helpful.
Sure. So,
Go ahead.
sure. I can sort of walk. The mental health call center is Multnomah County, is a county-run program. Urgent walk-in clinic is Cascadia Behavioral Health. Mobile crisis is Cascadia Behavioral Health. The Crisis Assessment and Treatment Center, CATC, is Telecare Corporation. Crisis Respite is Cascadia Behavioral Health. Emergency Department Liaisons is Cascadia Behavioral Health. And Crisis Prevention and Outreach is the Morrison Center.
So, and this is a real case, someone called me at 5:30 and said, my brother is a veteran. He is homeless. He has a drug and alcohol problem, but he needs a place to stay. I'm afraid for him because he's out on the streets. I'm afraid somebody's going to do something for him. So the first thing that I did, I called CATC, and I didn't know that I couldn't refer someone to CATC. And it would be helpful to see if this is referral bound, these different areas. And so I didn't have a cheat sheet in front of me, so I just told him what I thought he could walk into the CATC and get triaged, because I had just been there. And they said, no, he has to be referred either by Cascadia or by the police upon his release. I didn't know that. The police have to give him a referral to the CATC.
Oh, so this was an individual who is currently in jail? Is that?
No, he wasn't in jail.
Okay.
So when I called CATC, they said that the police can give him a referral, or from Cascadia, or someone from parole and probation. I think he was on probation. He was an older gentleman. His sister called or something like that. So I didn't know all these specifics, and I get a lot of these calls, and people say, well, what's the county doing to help with mental health? You know, like Joanne said, short of going to the hospital, into the jail, where can I? So what should I have done with this particular person?
So I would suggest that what we can do is provide you with some more information in a cheat sheet that would give you...
It has telephone
right,
numbers.
that help you with telephone numbers so that you can figure out in various different situations what to do.
That would
so we'd be happy to work with your staff
That would be really helpful. Misan is my new policy advisor, and it would be great if you could connect with her so that we can all have this at our desk, because I know we all get telephone calls about this. But this is huge, because when you break this out, it really kind of makes sense of where we're spending our dollars, and how it's being helpful to the community to see where there are the gaps. And I think the housing piece, I don't see that housing piece is the huge gap, Commissioner Shipwreck, that I don't see on here.
The housing piece is, oh, sorry, Commissioner.
Yes.
The housing piece is a huge gap, and you know, one of the challenges is the mental health treatment system isn't responsible for housing. They're really responsible for trying to connect people to housing and trying to support people to be successful in housing. So that's why you don't see that here. But it's a big part. It's a big challenge right now for us, as we are trying to help people both in crisis and getting out of the state hospital and in treatment in the community to find housing that they can afford.
So Neil, when you do this, can you put on that list of the cheat sheet of which one of these pieces of the crisis system does housing referral, so that if they're needing housing, that I know which one specifically to give them to?
That'd be perfect. I also want to encourage everyone, and I'll say it really loud, the Mental Health Call Center, 988-4888, is the place to call for any type of service information related to crisis, related to any type of outpatient service, addiction service, etc. They really are the hub of how to connect to any type of service in the county.
Thank you. Thank you.
Sure.
And Madam Chair, if
Yeah.
does Commissioner Smith's question about who provides the service and the had a tag-along question, which I'm not sure we got to, which was the budget question. And I'm thinking that even if Multnomah County doesn't provide the service, that our budget is, well,
Yes.
We pay for it, right?
Yes.
I'm going to change
Yes.
seats.
We both contract, we both deliver these services in this system, as Neil said, some of them with Multnomah County employees, and we provide funding. And you're going to hear from some of our partners in a minute. In some cases, they do some fundraising or bill to insurance as they can as well.
So referring back to the chart that just left our field division, that's okay, we all remember it. The services that aren't directly performed by Multnomah County are under contract to Multnomah County.
Yes.
I also just wanted to add real quick that on the Multnomah County webpage, on the front section, we always have the mental health crisis intervention phone number in case people didn't put that in their memory. They don't have to because it's on the internet.
It's always
Thank you.
there. So here's the budget for the crisis system. As you can see, it's just under $13 million. Medicaid funding attributes to slightly over half the budget, and that's probably somewhat increased over the last couple of years with the Affordable Care Act. Our county commissioners, and I always say this when I do a presentation on our crisis system, generously support crisis services with a budget just over $3.5 million, and the remainder is made up by state funding. The breakout of services by program, so our call center is about a $3 million program. Our urgent walk-in clinic is just under $2 million. Project Respond, just under $3 million. The CAT-C program, the subacute program, $3.3 million. Justice Triage, $680,000. The ED Liaison program, which is a 3 FTE program out to our emergency departments, is $273,000, and the crisis and prevention outreach for the Morrison Center is $120,000. So that's sort of the breakout, but we can put that all together and get it connected to those other slides as well.
Madam Chair, I have a question. So we're looking at the same pie. So you said the CATSI is $3.3 million?
Yes.
Is that's coming out of the county general fund?
Actually, it's supported by the county general fund, but its majority is Medicaid because those are Medicaid slots that are.
Okay, so you were breaking down the Medicaid, where the Medicaid dollars go.
The Medicaid and the general fund, the total. Neil was breaking down the total pie.
Yeah, I don't have right in front of me the breakdown of actually how much is Medicaid and how much is county general fund for each program.
He was doing the prior slide.
But we can get that to you.
Yeah.
Oh, okay. So I was trying to figure out if I'm looking at $3.5 million of our county general fund, and 3.3 of that is CATSI. That's what I was thinking. I was like, okay.
They're mostly these programs are a mix of Medicaid and general fund.
You were doing the prior slide, correct? Is that what you were going around the
Yes,
prior slide?
around the
That's
programs.
where
I was going around the
programs.
circle.
Yeah.
Yes,
The pie.
I can sneak back.
Madam Chair, I'm sure that we also have an interest in moving right along here, but I do want to say that there are a couple of themes. One of them is proportionality and the proportionate importance of this. And also there's a context issue that Commissioner Smith's question just raised, because and it also relates to what you were talking about, Commissioner Bailey, in relationship to the ACA, which is that this is part of a still greater system. Yeah. So just so that we keep that proportion in context, I do think that it all relates back to how we invest the precious resources, going back to your theme, Director Fuller. So just keeping that in mind as we proceed with the remainder of our presentations today.
The other thing is today we're focusing on the crisis system, but we would be happy to come back and talk with you about the Medicaid system. We've been doing some updates with the board over the last couple of years on the Affordable Care Act and the various different roles that the county has played in that. And we'd be happy to come and talk about Medicaid and the mental health system and the Affordable Care Act, if that was helpful.
Well, once again, excuse me, Madam Chair.
Go ahead.
Well, it's almost Groundhog Day. And this is my favorite metaphor for the way the county does our budget process. And I think that keeping in mind the proportionality and the context of an upstream image, how we can best have a lasting impact on people in our community who are suffering from behavioral health related crises is sort of the greater context of this presentation.
Absolutely.
So, Neil, you're going to walk forward with some recent additions?
I am,
Excellent.
David, I'm getting you out of line. So most recently, we added a interim program manager for the crisis system. Really, with the increased coordination among multiple systems across the behavioral health and physical health spectrum, there are increased demands on the crisis system to join stakeholder groups, gather and report data, and coordinate emergency crisis response. The crisis program manager was needed to help manage this effort and properly represent the county's role in providing oversight to the behavioral health crisis system. Before that, it was pretty much me who was the manager overseeing all the crisis system along with the other community mental health programs. And thanks to Unity, I get to go to a lot more meetings than I used to go to. So just that alone could eat up part of an FTE. I'm smiling at Chris. We also got some state grants, one of which added a resource room and the 1.5 FTE peer specialist, the urgent walk-in clinic. A crisis grant also added 2 staff to the Project Respond team, especially for high volume hours from 4 p.m. to 11 p.m. So we wanted to make sure that we had another whole team available to respond, especially if police were calling and needing assistance, as well as we added a peer specialist to this team. It's the first time this mobile outreach team has had a peer specialist. It's gone extremely well, and I believe another grant is around the corner, and I'll be back with a notice of intent in a week or so, where we want to add another peer specialist to that team out of that grant. And also the mental health call center, we've added a case manager 2 position. This is a position more focused on membership services so that our mental health professional counselors can focus on more of the crisis issues that they have to deal with. And we also relocated to a new facility. We're co-located with the health operations team. And this really is an excellent piece. Just the other day, I had an example where they told me someone had called into our mental health call center in crisis. As they sort of walked through the crisis, they found out there were medical components. In real time, they're able to connect that person to one of our county clinics and have the medical issue addressed as well, and really realized it might have been really the medical issue that was pushing the mental health crisis more than an actual mental health crisis. So that was a fantastic piece of that new.
In addition to that, I've been talking to the behavioral specialists that work in the clinic system, and they're thrilled at the co-location of the mental health call center with the call center that we use for clinic appointments, because they say that in real time they're handing people over on the phone to the call center when they're realizing that they're calling the appointment line, but they're really experiencing an acute crisis. They're suicidal or really depressed, and they really need to talk to someone sooner than they're going to be able to get a medical appointment in the clinic. So it goes both ways. It's been really a great partnership.
Madam Chair, I have a question. So the mobile crisis unit, I thought that was done by Cascadia. So do we contract out those 2 new FTEs to Cascadia?
We do.
Okay, great.
And now that we've talked about the goals, the funding, as well as the programs directly, we have a treat. We are going to bring contractors to the table and Pure Voice to talk to us about their unique spots in the system, the unique programs that they provide. So we will have Cascadia, Telecare, as well as Unity, information about the upcoming program, and Pure. So from Cascadia, we will have Jay Oslander and Dr. John Batlinsky. From Telecare, Kevin McChesney. From Unity, we have Dr. Chris Ferentinos. And Pure Voice, we have Ann Casper and I believe some invited guests. And we will be back.
Thank you.
So, Cascadia, why don't you come on up? Why don't you all come on up?
Morning.
Good morning, Chair Kafori, Commissioners. Thank you for the opportunity to speak with you today. Again, my name is Jay Alcindor, and I am the Senior Director of Cascadia's Crisis Services. Neil's presentation introduced our urgent walk-in clinic, our adult respite, and our mobile crisis teams, also known as Project Respond. Cascadia's crisis services also include our intensive transition team, which provides in-reach to inpatient psychiatric units to help individuals come back into the community, as well as a specialized response team called Healing Hurt People that provides support to individuals and families impacted by gang violence. So I'm going to speak just briefly about our urgent walk-in clinic and our mobile crisis teams. And I agree with Neil when he says that the commissioners have been generous in supporting the crisis system, so thank you. Cascadia's Urgent Walk-in Clinic is open every day of the year from 7 a.m. to 10:30 p.m. for anyone in the community. We provide behavioral health assessment, counseling, medication evaluations by our licensed medical providers, and linkage to community resources. Peer support services have become a critical element of our care. Individuals who visit the Urgent Walk-in Clinic may spend time in our Standing Stone resource room, where our peer wellness specialists provide a safe space, one-on-one and group interventions to help individuals build skills, find resources, and take steps. Individuals are offered access to computers, phones, and a variety of resources to support them in connecting to affordable mental health, medical, substance treatment, and other community services. We help individuals and their families in the most respectful, holistic, and timely way possible, and every visitor is treated as a unique individual with their own values, beliefs, culture, and life experiences. Our Urgent Walk-in Clinic is co-located with OHSU's Richmond Family Medicine Urgent Care Clinic, which affords us the opportunity to provide on-site coordinated behavioral health and medical care. So much as Neil was talking about having the two call centers, having our two clinics in one location has been a huge benefit. We welcome direct referrals from police officers at the Urgent Walk-in Clinic as an alternative to involuntary interventions or unneeded hospitalizations. Project Respond is open 24 hours a day, 7 days a week, 365 days a year, and again is available to any of us in the community. One of our main goals is to minimize the unnecessary use of police as first responders for people who are experiencing behavioral health crises. Project Respond provides immediate response to law enforcement within Multnomah County and serves as the mobile dispatch for the Multnomah County Crisis Line. Project Respond will often provide ongoing support following an initial crisis to help an individual and their support network gather resources to regain a sense of control and stability over their lives. Peer support services again play a significant role on our mobile crisis team now. We know that even in crisis, an individual can remain expert on what is likely to benefit them. We take the time to understand their unique circumstances and to maximize their personal preferences so that we may effectively address any safety concerns and reduce the need for unnecessary hospitalizations, arrests, or additional law enforcement contacts. Our crisis system has a commitment to protecting the rights of our clients, among them the right to confidentiality. While we safeguard protected health information, in situations where a potential of harm is present, we also must ensure that information flows to the responders who can provide the right level of response and who can best mitigate the risk without causing unintentional re-traumatization and harm. For this, we rely upon our partnerships that we have built, including with the Multnomah County Mental Health, the call center, crisis line, the police, law enforcement, and a multitude of others. We could not make the impact we do without the support of Portland Police in particular, and I do believe the behavioral health unit is ahead of the curve. Speaking of gaps, in 2011, we completed work on a 3-year performance improvement project with the Bazelon Center for Mental Health Law. Commissioner Shipwreck was on the steering committee, in fact. We looked at a sample of emergency calls involving Project Respond and the Portland Police to better understand the multiple clinical and systemic factors that put people with mental health care needs at risk of crises culminating in police interventions. In each of these cases, we determined a root cause for the police intervention. We took a step back and examined why the police contact had occurred, determined any resources, supports, or actions that could have been in place beforehand, negating the need for a subsequent unnecessary police contact. We expected to find not having the access to the right level of care or the right services at the right time, such as housing support, mental health care, inpatient treatment, substance abuse treatment. We expected that would be highly correlated, and we did find that. What we also found, and what really struck us, was in our analysis, we found that sharing information, something as fundamental as that, might have likely prevented the police contact in 78% of the cases we examined. There were people who were concerned beforehand. Somebody had asked for help in some way, but the vital information never made it in a coordinated manner to the people or the entities who could have helped with an earlier intervention that might have negated the need for a police intervention. Also, to answer your question, Commissioner Bailey, about success, it used to be that less than 10% of the individuals we saw in the crisis system had health insurance. Over the last year, we've seen it go above 50%. So that's a plus. Thank you again for the opportunity to speak with you.
Madam Chair, I have a question. So where is your walk-in clinic? What's the address?
4212 Southeast Division Street, so that's right at Southeast 43rd and Division.
And people can walk in there from 10 a.m. to
7 a.m. to 10:30 p.m. every day of the year.
And how do people know about this? How do you get your referrals?
Well, we spend a lot of time educating everyone who will listen. We also, the Portland Police have been kind enough to, at the end of all their alerts, they list the National Suicide Hotline, Lines for Life, and the walk-in clinic information. And so we really just try to make sure everyone knows about it. And we also spend a lot of time talking about the crisis line, and that really is a number that anyone in the community can call, and they can help get you to the right place.
Thank you.
Any other questions? Thanks. Who's next?
Okay.
Good morning.
Well, good morning, Chair Kafuri, Commissioners. My name is Chris Ferentinos, now Vice President for Unity Center. So I'm here to talk about Unity, and as all of you already know, this unprecedented collaboration between 4 health systems coming together, Legacy, OHSU, Kaiser, and Adventist, towards a better, more coordinated response to the crisis that happens today in our hospitals and REDs. By the way, I think I come with a hopeful message, but also with a reality check, because when we look at the numbers that you just looked, our hospitals combined serve in our EDs today per year about 17,000 behavioral health patients per year. Which is a huge number compared to the numbers that we looked here. So in reality, the emergency departments are probably the biggest safety net for mental health in Multnomah County. Notwithstanding the amazing job that all of these other services are doing, we're still having a lot of individuals that are taken to the hospital or to jail, as we know so well. So Unity comes as a response to that ED crowding. This morning I opened my email. There are 32 patients boarding in the 5 hospitals of Legacy waiting for beds. So that's the kind of stuff that we're dealing with. So Unity will have this inpatient component where we're going to have 102 inpatient beds, 22 of those for child and adolescent, and the rest of them 80 for adults. And the psychiatric emergency service, which is really what we're talking about today here, which is a better model to treat individuals presenting with behavioral health emergencies, because it's a model where you have the right professionals at the right time to serve a person in an emergency, in a crisis. It's an observation model. It's a model that people can stay under observation up to 23 hours, and then have a decision made at that point whether that person needs an inpatient hospitalization or can be discharged back to the community. I think another innovation in what we're doing is this co-location of with community-based organizations and navigators that will help create a better transition of care. We have a transition of care work group. We have done some mini improvement plans, Kaizen events with the community. We're now transforming it into a monthly meeting where we're inviting all of the services that you heard. We have been actually at the table already for 2 years. But we're going to increase now that to every month and to really figure out how it's going to be that co-location. How are we going to work together? Who is going to sit at the table, where and what, to do what, and talk to patients, et cetera, to help that transition. We also hope to have co-location of transition services and peer services at Unity. In fact, I think if I am to speak about one of the gaps in our system is the individuals who can actually help patients transition from one level of care to the next. A lot of the individuals that we treat, they are very vulnerable. They are in one of the most vulnerable times in their lives. And having peer support services, in addition to the mental health providers that are helping, it's fundamental to help these individuals make to the next level of care. So if there is a gap, and in addition to all of the gaps that have been spoken to, I think one of the ones that came out in some of the Kaizen events that we did, in process improvement events that we did with the community, was the need for more peer services in Multnomah County. We're also going to be co-locating the commitment services, so that will be a great time saving and coordination saving for both individuals, court judges, and commitment counselors. And speaking of information, one of the things that we're pushing quite a bit in the Unity work is creating a portal of information for all stakeholders out in the community that can actually access our medical records. So that's called Epic Care Link. Today, all of our hospitals use Epic, which they can sort of kind of talk to each other, but community-based organizations, up until recently, did not have a look into what happens in the hospital. And by doing that, by creating that free connectivity with all of our partners in the community, we expect that a lot of the communication will be resolved. It doesn't resolve all of it, but it resolves a part of it. I think also I would like to emphasize that the opportunity that we have with Unity is to like Joanne Fuller said, is to observe, is to have the amount of data to observe what that ripple effect will be. I think all of the other services are fundamental. They exist today. I think what Unity brings to the table is a much better care for emergencies. It's also behavioral health emergencies. Also an opportunity to diverge from a very expensive inpatient hospitalization, individuals that could do well in an observation model and could go to a lower level of care, to CAT-C, subacute, to respite, or back to their homes or shelters or housing, that's another story. So anyway, we're planning to open at the end of this year. And we hope to serve the community and continue to collaborate with all of these partners the way we have been. All of us sit in several different tables together now, week by week, coordinating our services. Thank you.
Thank you.
Madam Chair, I have a question. I like the idea of bringing the community-based organizations online. One of the concerns I have is, have you put in the protections of the individuals as it relates to the HIPAA Act in terms of who has access to folks' medical information, and how is that going to work?
Yeah, absolutely. So the system that we have in place, it's very protected. It's password protected. We only there's a whole protocol to actually allow a community-based organization to have access to the records. They have to have a HIPAA compliance officer. They have to comply with all of the HIPAA rules and regulations, and it's all password protected, etc. And the person on the other side has to have enough information about who they are trying to visualize the record to be able to access. So there are several layers of protection that our hospitals have and Epic has put in place to
just for the
protect.
community-based organizations?
Yes.
Okay.
This is for the community. So this is for Cascadia, for instance, the intensive transition team that Jay was talking about. The intensive transition team they have permission. They're working with individuals that are transitioning out of legacy back to the community. The intensive transition team has permission to look at the record, so they can actually be doing the coordination of care, already seeing what's happening to that person. But they have to have passed a threshold of security, password protected, several different instances to be able to see that.
Okay. Thank you.
Thank you.
Chair Kafori, Commissioners, thank you for listening to us today. My name is Kevin McChesney, and I'm Regional Operations Director for Telecare. In front of you, you've got a report for both the Crisis Assessment and Treatment Center, the CATSI, and also what we now call the community pilot, mainly because there turned out to be some issues with referring to it as justice triage, simply because people had a bad reference to justice, so we changed the name to community to make it more welcoming and open for people. So I won't go through those reports in detail, but I do want to give you some highlights. So for the Crisis Assessment and Treatment Center, since it opened in June of 2011, we have served just over 1,700 unique individuals. Those individuals have had around just about 2,700 admissions during that time frame. I'm proud to say that during that time we have done no seclusions or restraints. In terms of referrals, 68% of the total referrals come from emergency departments. So what I would expect when the Unity Center comes online is that they will pick up a huge percentage of that, and the emergency department percentage will drop in a like amount. 21% of those come from community sources, and earlier on in the history of the CATSI, that was more like 15%. So I think that's great that we're actually capturing more people coming from community settings, either outpatient clinics or from Project Respond, and so they're not even getting to the emergency department. I think that's always a good thing. In terms of discharges, 63% of the discharges go back to a home, family, or friends. Only 14% go to a higher level of care. So those are people either psychiatrically or too psychiatrically or medically acute for us to maintain at a subacute level of care. Unfortunately, 14% of the people that we discharge are still going to shelters. So I think that highlights the housing shortage that we have in the metropolitan area. Some of the themes from the report: recovery comes up a lot in terms of the comments from the people that we serve. So it's really clear. We really try and take an individualized approach that utilizes an interdisciplinary team that includes a psychiatrist and includes an RN, but we're really focusing on that individual's unique needs and situation and sort of letting them tell us what they need. I think the other really important thing is, and I've heard it a number of times today, peers make a huge difference. We have 2 on each shift, and a lot of the comments you see in that report are about how the peers really connected with individuals. I think there's one person quoted in there who wanted us to give them 4 of them raises. So they really value that contribution from people who have a similar experience to theirs. And then I think the other key thing is that the space itself is very welcoming and comfortable, and that it helps create a milieu for the people that we serve there that they find very comfortable and a nice place to start on the road to their recovery. I did want to mention too that we're adding some new services beginning this month. We've created a series of co-occurring education groups, and again, they're education related, not treatment related, but there are 16 unique learning sessions. We don't have a length of stay long enough for most people to complete all 16 sessions, but they each stand alone. They have a different topic, and we really feel like that's going to help raise the level of conversation around substance use issues. In addition to that, or as part of that, we are also implementing what's called an SBIRT evaluation, or a screening, brief intervention, referral to treatment. It's an internationally recognized evidence-based practice, and what it really does is it screens people for drug and alcohol use, and then provides a brief intervention to try and increase engagement and maybe get them to start working on some of their substance use issues. We're doing that at admission for every individual, and then again at discharge. In terms of the community triage, that's open 24 hours a day, but only 4 days a week, so Monday through Thursday. Closes at 6 a.m. on Friday. We picked those days because what we really found out is we get most of the referrals during weekdays and not on the weekends. We have served 196 people there since September of 2014, and a little over 56% of the referrals come from the Multnomah County Detention Center. There was also just a recent increase in that. In December, there was a new supervisor there, and we did some outreach both to them and to parole and probation, and there was suddenly a spike in referrals, which we really enjoyed. 33% are referred from the mentally ill offenders unit from parole and probation. In terms of services provided, 67.8 receive assistance or community referrals. So broad range of services, from food to clothes to help with getting identifications, social security numbers, but then there's also referrals for aftercare services, linkages to outpatient providers, substance use services, just a broad range of services in the community. 26.5% of the people were admitted to one of the 2 dedicated beds for the community triage program in the CATSI. And only 3.5% are referred to EDs for psychiatric or emergency medical services. Themes here, nearly everybody we see gets a mental health assessment and a medical screening within 1 hour of arriving at the community triage program. It's really seen by a lot of the people as a place of refuge. There's a bunch of recliners there, so they can sit and relax, have some food, have people to talk to, while we start to make arrangements for them to be referred elsewhere. The one other thing that I wanted to add is I think the limited hours of operation do impact the number of people that we can serve. If we could just operate 5 days a week, that would really increase the number of people. It'd get us to 6 a.m. on Saturday. And would capture those people that need services on Friday as well. And we have to cut off referrals earlier so that people who do come in we're able to be able to successfully move them on when we close at that 6 a.m. time. So.
I've got a question for Kevin, if I could. So while you're talking about a budget-related issue for us, like being open an additional day, is any part of your service reimbursable by Medicaid?
A limited amount of it is. I mean, to the extent that there's a third-party payer involved, we can try and seek reimbursement from a third-party payer.
So a third-party payer would mean that a person presenting themselves, say, to the community triage program was covered by the Oregon Health Plan coverage.
Yes, we should be able to bill for those services.
So, I don't mean to lead you down the line of my conjecture. There's a question in here somewhere which has to do with, do you see an increase in the percentage of people presenting themselves to your program who have been signed up or who have signed up for health care?
I don't have those numbers specifically for the community triage, but for the CATSI, we noticed a drop from somewhere in the 40 to 50% range for people who did not have coverage to something like 20 to 30% after the implementation of the Affordable Care Act. So, I would expect a similar sort of mix at the community triage.
So I guess the conclusion that I'm driving at here is that opening up for an additional day now with the additional coverage for people who present themselves is going to cost the Multnomah County General Fund, should we see that as being a wise investment of our precious and limited resources, would cost us about 50% less if we've reduced from 50% without coverage to 30 to 20% without coverage, 50% less, because that is being now covered by a partnership with Medicaid.
Yeah, well, again, I don't have the numbers in front of me in terms of what sort of coverage people do have, but it would depend on, it would depend on their coverage, I think, is the short answer, because some insurances may not cover that service. So we'd really have to look into that more, but I think there's definitely the potential to get some third-party reimbursement that would help offset some of the general fund costs.
No, I'm just suggesting that it would be a good part of your advocacy with the group that you're speaking in front of today, that any increase would, in time, would be the burden would be shouldered somewhat by Medicaid.
It is duly noted.
A word to the wise.
Madam Chair, yeah, I do have a question, but you don't triage on that day, but you're open upstairs, but you're just not triaging downstairs, but you're open because people are living there. Can you make that distinction? Because I think that people have the wrong idea about what this is. It's open. You're up for business, but you're just not taking any new folks in on that particular day that you...
Well, the CATSI is still open for business as usual with normal referral sources 24 hours, 7 days a week.
Right.
It's just that community triage that is not available during that time frame.
And people are living there 30 days out of the month. So what I heard you say is basically the majority of the folks who go there they have private insurance?
To
the CATSI?
and again, I don't have the numbers in front of me, about 80% of them. Because one of the things that, of course, puts people in crisis is lack of resources. And if they're homeless, they may not have, applied for insurance. So we still see a fairly significant number of uninsured people at the CATSI.
But for the most part, 80% of the folks are privately insured.
Yes.
Okay, thank you.
I'm sorry, did you get that correct? 80% are privately insured?
I'm sorry, they're really publicly insured.
Thank you.
Okay.
Yeah.
I was going to say
to clarify that.
Okay.
Yeah, we should differentiate that. Yeah, they're Medicaid coverage, not private insurance.
Thank you for clarifying that.
Now, may I say just one thing about telecare? I just want to give them kudos for the model that they have created. Is very trauma-informed, and to the extent that Unity decided to contract with telecare and the folks from CATC to actually train our staff on the model that they deliver care in a very trauma-informed way. So I want to just say kudos to them.
Thank you. All right.
And so I would like to say thank you to all of our partner providers for continuing to do a great job serving our community and your time today. And we would like to move forward to one of our next group of community experts, and those are our peer voices and consumer advocates. And I would like to introduce Ann Casper, who I've had the opportunity and enjoyment to work with for, the last decade, I think, Ann, in a variety of different advocacy roles she's played supporting our work here at the county. And she has also brought a couple of guests with us, Arlene and Lakeisha as well. So Ann, would you take it away, please?
I will. I've got to get set up here. I'm an old teacher. I have a lot of materials. Thank you, Chair Kafori, Commissioner Bailey, Commissioner Smith, and Commissioner Shiprack for having me speak today. I think this is the first time an independent peer has been invited to speak to you at a mental health briefing, and it's truly a privilege. It's also very difficult because I think the last numbers I heard from a peer who looked it up, there's 160,000 people basically taken care of by Multnomah County, and I'm only one person, and I cannot speak for everybody. So I actually emailed about 700 people, and we have some people here today from the City of Portland, the police, and a lot of peers. Can you guys stand up who came today? Thank you very much. Thank you for coming. So it takes a team to do this all together. The latest disease diagnosis I got last time I was in the hospital in Good Sam was something I think we all can be diagnosed with. I can't believe what it's called. Exacerbated exhaustion. Really. So in the next few minutes, I will share 3 requests, talk about successes in Multnomah County emergency system, and I plan to have you participate in an exercise. So these 3 requests, commissioners, are coming to me, coming from me, because no one wrote to me about what they wanted to say about the county system. So this is coming from me. And it's about preventative care. Number 1, create a Multnomah County Department of Peer Empowerment with 4 full-time employees based on the Alameda County model of the Department of Consumer Empowerment, where they hire 6 full-time peers and many part-timers. So I was just there 2 weeks ago. I paid my own way down to look into the Unity model down there, and I found it was really great. That model at Alameda County is great. So in that department, we can have a peer leadership academy. So we can get new peer leaders educated, supported, and trained to work at managerial levels in the community agencies and on public committees. And somebody said in their campaign literature that we should be getting $15 an hour, so should peers, and we need the advocacy at that level. So they can be champions for peer support specialist employment. Right now, the health department is creating many jobs for community health workers. And so a couple of years ago, I was invited by a counselor in the jail system to go and be a peer support specialist as a volunteer in the jail system. It was a very important time. And I worked with Joanne Fuller and Judge France and Commissioner Shiprack for 7 years on the Lipstick Committee. And we actually made a position for peer support specialists. We asked Lipstick to help with that. And unfortunately, according to Multnomah County's, from me, unfortunately, according to Multnomah County's Nancy Griffith and the corrections system, there are now community health workers hired. And as a peer support specialist, I can't work there. So I would like you to think about making sure that we are champion for peer support specialists. And Commissioner Smith, yesterday at Highland Church, you spoke about paid internships. We need internships for peer support specialists. Multnomah County actually pays for 40 people to be trained each year as a peer support specialist. Thank you very much for that. However, they need experience. to do that. Number 2, independent database for mental health crisis plans, not tied to clinics, hospitals, insurance, or government agencies. Peers can share with their systems when they choose to. So this is crisis plans telling what kind of medications, where we want to go, so things like that. And again, Commissioner Smith, you talked about promoting tech companies. I'd like to say this would be a great project to work on open source networking and use open source tech companies, because that'll be affordable. And number 3, alternative care, such as acupuncture, spirituality, nutrition, diet plans, art, music, dancing, and for me personally, getting back to Italy, because that really helped me, as Commissioner Shiprock knows. So just a little bit about my own life. Why am I speaking up here? Why did they ask me, besides I bother all these people all the time, right, David? So I received and still receive care at a mental health public agency. I've been on 27 different medications. The last 7 times in the hospital has been because of coming off of medications. We need to study that a little bit more, and that's under professional care. I've been brought by force to hospitals by police in handcuffs. I was brought by ambulance and charged over $1,000 each time. I've been physically restrained and taken to the hospital by my family and friends because, unfortunately, I wouldn't go willingly. And I was driven by secure transport to the Cascadia Walk-In Clinic, and they had really bad country music playing. I'm so happy that you have peers there, because when I went there, there's no peers, and I walked out. And I have been taken to the courthouse in the sheriff's car in handcuffs to my commitment hearing. Thank you, Chris Martinez and Unity. You're going to solve that problem. People won't have to be out in the public in handcuffs. So I've been a frequent flyer, and I've lost my civil rights 6 times. And so I have a story. We don't have time today, but Benjamin Hale, my lawyer Benjamin Hale, and I, who appealed the commitment, got the appeal. Just quickly, it came out in my name. So if you look up under Ann Casper, State of Oregon, it comes up, my whole case. And Benjamin and I got it, so when you release records, it's only by initials. You know, it's really hard to date when people are looking you up and they see you've been committed. So my life is not all that bad. I have a master's in applied linguistics, a bachelor's in international economics. I've taught at the university level. I worked with 500 refugees. I speak French, German, Japanese, and some Italian now. And I have a 4-bedroom house in the Elliott and Irvington neighborhood. Been to 17 countries, worked at import-export with Sam NATO. I worked overseas for 2 years, and most importantly, I've become a really bad belly dancer. So what has helped me from being a frequent flyer in this system right now? It's been peer support and having a purpose. If I have a purpose, then I don't need all these emergencies things. So what is peer support? Meeting the person exactly where they're at, no judgment. If they're hearing voices, that's okay. I know this is very different ways of thinking. We don't attach to outcomes. And that person has been very hard as a peer support specialist. It's strengths-based. We hold hope, demonstrate recovery. And, hey, you guys, these are my peer support specialists. Actually, I'm getting kind of nervous. Can you help me? I'm getting my throat all dry, and I'm getting this really hard. Yeah, can you help me, please?
Well,
here, speak in the mic, not to me.
I would just tell you, you're here because you believe in what you're doing. Mm-hmm. Try to focus on that and just breathe.
Okay.
Go ahead, we're with you.
Mm-hmm.
You're doing an excellent job, you know. I've been there too, you know. Just breathe it out.
Okay.
And I'm right here with you to get through.
Thank you. Actually, that really did help. I am very nervous. You guys make me so nervous. 3 really successful things. AMSAC, the Adult Mental Health and Substance Abuse Advisory Committee. I was the secretary and chair. It was very important. When I was really depressed, sleeping 18 hours a day, going to that meeting for 2 hours a day made a difference. It made me feel good. We have Amy Anderson, who's the chair here. Thank you. CATSI, the Telecare Crisis Assessment and Treatment Center. After James Chassie died, I was invited by Mayor Potter, just saw him yesterday, right, to be part of the Mental Health Commission, and we dreamed up CATSI at that table, working with the police. I'd like to say thank you for David Hidalgo. He actually had us, a few of us peers, help write the RFP, Request for Proposals, in peer language. He was also very instrumental in the design, and it looks really good. I ended up working there for 3 years, didn't plan to, and I am so proud that I worked there. It's based on the recovery model, and people actually want to go to CATSI. I know you don't hear always from the people on the street they want to go to CATSI. Mike at Good Sam says, hey, why do all these people want to go there? We can't refer them all, and they can't take private insurance. People do repeat, but they get stronger each time. So they will stay out of it. I say we because I still feel part of the program. We keep people out of jail. We keep people alive. And it is based on the recovery model. I felt like a family working there, and we're so proud that the family, part of us are working in St. Vincent's, Providence, other places, maybe Unity. We're spreading that recovery model. So the 3 things I'm asking for is Department of Peer Empowerment, an independent database, and alternative care. And speaking about money for things, I don't have it up me. Oh, yes. I saw in the newspaper you're getting some money, so maybe we can use some of that. My friend Lloyd Pittman says we can give people housing, but they need support to stay in it. So think about that. I also have some information. NAMI, the National Alliance of Mental Illness, is another great resource. They have a peer answering phone calls there. I'm going to give you the handout that they give, which also includes information on domestic violence, which is so important. There's something called trauma-informed architecture. So thinking about when we build new programs, what we can do to make people feel very comfortable. I'm giving you also some information on peer support salaries around the country, and also here in this area. So I'd like to share a quote from Dr. Martin Luther King. I watched it 3 times on YouTube, spending time at Highland Church and also Maranatha Church, and listening to Dr. Bethel and Dr. Haynes. It just kind of reminds me, we as peers are still working to be equals, but we will all work, because we're all peers. We're all people who've been through trauma, and we all work together. So this is his quote. There are some things in our nation and in our world to which I'm proud to be maladjusted. I never intend to adjust myself to segregation and discrimination. And I call upon you to be maladjusted to these things until the good society is realized. Yes, I must confess that I believe firmly that our world is in dire need of a new organization, the International Association for the Advancement of Creative Maladjustment. Through such maladjustment, we'll be able to emerge from the bleak and desolate midnight of man's inhumanity to man. I'm going to say this again, man's inhumanity to man, into the bright and glittering daybreak of freedom and justice. Thank you.
Thank you.
Wonderful. Thank you, Anne. Really appreciate you coming forward, sharing story, voice, and also a great live example of peer support, right as we were watching.
Oh, David, you know me, I always have one more thing to say. Excuse me.
Go right ahead, please.
So I was in Japan 20 years ago in the hospital, and so I spoke Japanese, so that helped out the doctors. But I want you to think about really care for people who don't speak English, care from different kinds of communities, and one of the, yes?
Culturally specific.
Yes, culturally specific, because for me, working with refugees is really important. So this man, so the Japanese, in Japanese hospitals, you had the women on one side and the men on another. We could meet in the garden. And this man gave me his book, the only book he had in English. And it means so much to me because he wanted to support me there.
Right.
So.
Great. Thank you. And any other questions for Lakeisha Aline? All right. Thank you very much.
I'm sorry, Commissioner
One more
Bailey, I have a
question.
Commissioner Bailey.
So this is actually a question for you, David.
Yes, please.
And we've heard wonderful testimony here from these peers. We heard from throughout the presentation today the importance of peers in the process. So I guess one of the questions that I have for you, and it's sort of a multi-part question, we can talk about it now, and then if there's more information given the time constraints, you can follow up with me or anybody else who's interested. But I'm curious, given the expansion that we've had from the Affordable Care Act, the number of folks that we've served, and the ability we have to serve more people, how have we then also integrated and expanded our work with peers to make sure that we have a system that's working for everybody? How do we plan to do that going forward in the next fiscal year beyond sort of the 3 formal advisory councils that we have? And then we also heard about paid support services from peers do we have a plan for that in the budget as we go forward?
Sure. Let me see if I can touch on all those, Commissioner Bailey. So in terms of the history here in Multnomah County, Ann also alluded to, the county has for approximately the past 8 years had a contract with NAMI to train peers in peer-based support, several different programs. Once the state had come forward with a certification process, we also put an RFP out to ensure that the peer-based programs that the county contracts with for education, support, and training met that certification requirement, so people could subsequently be certified and go out and be employed in the community. We also have peer-based programs that the board has continued to support. North Star, in terms of employment, is another peer-based service program where individuals can go ahead and get the support and help they need to move forward in employment, and as Ann mentioned, have productive and goal-oriented activities every day in their lives as well. Part of what we do, and as the Mental Health and Addiction Services Division, is we don't tend to provide all the services. We are more administrative than a service provider. What we do tend to do is we contract out a majority of our services. So we rely heavily on the network of contractors that we have in the community, for contractors for individuals that serve people who have a more chronic condition, people with serious mental illness. All of those contractors have peers on staff. Various agencies are in different points in their development of integrating peers into the service system, and we'd be happy to provide more information as well to ensure that the board is aware how peers are being used in the treatment system, as well as supports for individuals. I think also Dr. Ferentinos also mentioned the goal to have peers assisting with navigation through the system to provide support. You've heard also that in the crisis services system, we've added peers in that part of the system as well. So globally, we are looking at adding peers in all components of the system. Additionally, internally at the county, in our jail diversion programs, we have peers also. In our early psychosis program, we've also employed peers in that program. So we are certainly pushing forward. There is, I can certainly say there is a need for more peer voice, more peer engagement in our community. We'll continue to use our advisory committees for that support as well. They are a great avenue for us to come together with the community and for them to help us reach out further. So those would be the things I would say initially right now. As we look to FY17, we will continue to bring forward the opportunity to go ahead and continue funding the peer support programs and hope to grow that over time.
Thank you.
Yes, absolutely.
Madam Chair, if I could.
Thank you very much.
I really appreciate this. Thank you, everyone, for your testimony, and it's always good to see you. And I really do appreciate the example of peer support, which sort of helped me breathe through the presentation as well. So thank you very much. I think that we also benefit from this concept, which I wrote down because I thought it was extremely helpful for us as policymakers, this concept of transition from one level to the next, that we are not stuck providing services in accordance with the current service model, that we can prioritize, that we can learn from the evidence, and that we can truly be engaged in a recovery process and an improvement process. And I also wanted to point out that something that was really mentioned only kind of in passing today is the other option that police have besides taking people to the emergency room, which is taking people to jail. As it was pointed out by last year's grand jury, the corrections grand jury, and by, I can't think of any grand jury that preceded this last year's corrections grand jury report that has not pointed out that the corrections system has unintentionally, and I'm quoting from them, the corrections system has unintentionally become the community's main resource to treat mental illness, although the system is not funded or resourced accordingly. So the work that we just heard from today is also a tremendous, tremendous resource to divert people who have a health issue from a system that has a punitive, not health-oriented focus. So this is tremendously positive. Just to go on, just one more factoid from the Corrections Grand Jury report. 43% of inmates are affected by mental health issues. So thank you again for your work and for your presentations today, all of you.
Absolutely. And I noticed that we have reached 12 noon, but would just like to wrap up quickly and acknowledge that we did receive some information requests to bring on back. We will happily provide that. The other thing that we want to ensure is that as we learn more about the Unity project, the final kind of development stages of that project and the liftoff, we will bring that important information as well. I think as Joanne had mentioned as well, once that program lifts off in the community, one of the lessons learned that we have had from a prior program, the Crisis Triage Center, not the CATC, but the CTC, is that when you bring large new programs into the community, what you don't want to do is immediately disband your other parts of the system. Each one of the new programs that come into this community that are filling a gap, of course, have an impact on the rest of the system. So what we would like to do is ensure that we bring information back to you in terms of data about how the other crisis programs are being used and utilized once the Unity project lifts off, and then we can continue to talk about the impact and what gaps are as we learn more about that. And it seems appropriate to close with the mental health crisis number. So everyone has that number. I think 3 times gets it into memory. So it's 503-988-4888. That is number 24/7 available for anyone to get help about mental health information or how to get support in the community. Thank you very much.
Thank you so much. Any other questions or comments from the board? All right. Thank you again. Thanks everyone for coming today and those in the audience who came to listen. Seeing no further business, we're adjourned.